Welcome to week 9, part 1. This week we are looking at coronary artery disease and acute coronary syndrome, and that'll be part 1, and part 2 will be cardiogenic shock. So at some point during your career, you will come in contact with someone who's having angina, who's having an MI, who's going for surgery, because it is the #1 killer in adults, right up there with cancer. So at some point you will come across an issue with coronary artery disease. So it all stems from atherosclerosis, which is a type of blood vessel disorder. It begins as these soft deposits of fat that harden with age, and that's why it's referred to as hardening of the arteries. So atherosclerosis can occur in any artery in the body, but there tends to be a preference for coronary arteries. And the proper terminology for these fatty deposits are atheromas. So you'll see many different types of terminology for coronary artery disease. Individuals call it arteriosclerotic heart disease, cardiovascular heart disease, ischemic heart disease, and what I'm terming it today is coronary artery disease. So atherosclerosis is the major cause of coronary artery disease. And so what is that? So it's characterized by this focal deposit. So meaning a very specific, not along the whole lining of the artery, but these focal deposits of lipids, primarily within the intimal wall of an artery. So what's an intimal wall? So intimal definition is the most innermost membrane or lining of an organ or this part of the artery. And it's especially found in the artery, vein, or lymphatic system. So it's the major cause of coronary artery disease. The endothelial lining is injured through injury and inflammation. So how is it injured? Well, it's injured through tobacco use, hyperlipidemia, hypertension, toxins, diabetes, and infection, which causes an inflammatory response. So atherosclerosis is all about this inflammatory response. So if we look at the pathogenesis of atherosclerosis, we start off with A up here, the damaged endothelium. And I've given you some examples here of what damages the endothelium here. And so as I've said, coronary artery disease, it's a progressive disease and it develops in stages. And when it becomes symptomatic, the disease process is usually well advanced. So when it gets to that symptomatic part, it's in the advanced stages. The stages of development in atherosclerosis are first this fatty streaks. So you've got the damaged endothelium here. And then what happens is you have this fatty streak that happens. And the fatty streak is the earliest lesions of atherosclerosis. And it's characterized by this lipid smooth muscle cells that form. And as the streaks of fat develop within the smooth muscle cells, a yellow tinge appears. So you've got this yellow tinging appearing in here in the smooth muscle. The fibrous plaque here is the beginning of the progressive changes in the endothelium of the arterial wall. These changes can appear in the coronary arteries by age 30 and increase with age. Low-density lipoproteins, which we'll speak to in a moment, and growth factors from platelets stimulate smooth muscle proliferation, so the breakdown and thickening of the arterial wall. Normally, the endothelium repairs itself immediately. However, this does not happen in people with coronary artery disease. So this is your fibrous plaque. And then the complicated lesion is the final and most dangerous stage. As the fibrous plaque grows, continued inflammation can result in the plaque becoming unstable and ulcerated and rupturing. And so once the integrity of the artery's inner wall is compromised, platelets accumulate in large number, leading to a thrombus. And so this is the thrombus formation here, and that's what causes the occlusion. So it all starts from this damaged endothelium, and then it grows, and it grows a little bit more, and then you have this rupture of the fibrous plaque, and the platelets come to heal it, and you get the plaque development and a thrombus. Now, one of the things that does happen is collateral circulation. And so normally some arterial asthmoses or connections exist within the coronary system. But collateral circulation exists in individuals where they develop and they grow these collateral small vessels around an area that has been a plaque has developed. And so it's kind of just a response of the body to these blockages. And so when occlusion of the coronary arteries occurs slowly over a period, the chance that adequate collateral circulation will develop is greater, and the myocardium will receive enough oxygen and blood. However, with a rapid onset coronary artery disease or coronary spasm, the time is inadequate for collateral development, and a diminished arterial flow results in more severe ischemia or infarction. Now, two factors are related to collateral circulation. So the ability to develop new vessels, which is angiogenesis, and the presence of chronic ischemia, which is telling the body to produce this collateral circulation. So this is a great diagram of collateral circulation. So in A here, you have an opening functioning coronary artery. In B, you have a partial coronary artery obstruction or a closure with collateral circulation. You can see here starting to be developed here. And in C, you have this total occlusion of the coronary artery with collateral circulation actually bypassing the occlusion to supply blood to the myocardium. And what happens when the collateral circulation starts to break down is when you actually, again, will start to develop the symptoms of significant coronary artery disease. Typically, collateral circulation can't sustain a full closure of a coronary artery. It does help in the process, though, before a heart attack happens. So coronary artery disease develops over many years, and the clinical manifestations are not apparent in the early stages of the disease. Therefore, it's extremely important to identify people at high risk and to initiate therapeutic lifestyle changes and treatment strategies early. So let's talk about the risk factors. We have non-modifiable risk factors and modifiable risk factors. So the non-modifiable ones are age, gender. Typically it affects more men than women until the age of 65. Ethnicity, it's more common in whites than blacks. If people have a family history, it's very common to have a genetic inheritance. And hypertension, I've put it under non-modifiable, especially if you have primary hypertension where you can't, your body, causes your body to be hypertensive, but not related to any risk factors like eating too much salt or things like that. There's hypertension could be a primary cause and a secondary cause. This is primary hypertension. What about the modifiable risk factors? So the modifiable risk factors are elevated serum lipids. We have two types of lipids in our body. We have high density lipoproteins, which are the good. They carry lipids away from arteries and to the liver for metabolism. If the low density lipoproteins are elevated, that causes increased coronary artery disease. The second major risk factor is hypertension, and it's defined as a blood pressure greater than 140/90 or 130/80 if the client has diabetes or chronic kidney disease. In postmenopausal women, hypertension is associated with a greater incidence of coronary artery disease than men. Hypertension increases the risk of death from coronary artery disease tenfold, so it's really important to get people's blood pressure under control. The third major risk factor is tobacco use. The risk of developing coronary artery disease is 2 to 6 times higher in those who smoke tobacco or use smokeless tobacco than in those who do not. Further, tobacco smoking decreases estrogen levels, placing premenopausal women at higher risk for coronary artery disease. And risk is proportional to the number of cigarettes smoked. The fourth major risk factor is physical inactivity, and it implies a lack of adequate physical exercise on a regular basis. Other risk factors are obesity. The mortality rate from coronary artery disease is statistically higher in obese people. And obesity is defined as a body mass index greater than 30 kilograms per meter squared. The incidence of coronary artery disease is 2 to 4 times greater among people who have diabetes. And my life I did most of my career in cardiology, and the amount of people that came in with angina and heart attacks were diabetics. So it's got a significant correlation. Studies are also focusing on a disease called metabolic syndrome, what looks at this high cholesterol and high diabetes and hypertension. Other things are the psychological states, and these could be things such as depression, acute and chronic stress, anxiety, hostility, anger, lack of social support. And those are the big ones that are other modifiable risk factors. This is just describing metabolic syndrome, what it is. So it's a cluster of conditions of blood pressure, high blood sugar, excess body fat around the waist, and abnormal cholesterol and triglyceride levels. And all of these combined increase your risk of heart disease, stroke, and diabetes. So health promotion. Prevention and early treatment of coronary artery disease must involve a multifactorial approach and needs to be ongoing throughout the lifespan. Management of high-risk persons starts with controlling or changing the additive effects of those risk factors that were discussed. So some of the things that you can focus in on are physical activity. The recommendation is 30 minutes on most times of the day. Regular physical activity contributes to weight reduction, a reduction of systolic blood pressure, and in some men more than women, an increase in the good cholesterol. Examples of moderate physical activity include brisk walking, hiking, biking, and swimming. Nutrition is very important, and incorporating health education in schools, because coronary artery disease starts as a child. So health education is very important. For nutritional therapy, it's looking at the increase of omega-3s is very important. So it's found that eating omega-3s twice a week from fatty fish is very important in decreasing the incidence of coronary artery disease, as well as a low salt, low fat diet are very important as well. And low fat and low cholesterol and low simple carbohydrates. So that's the sugars. Cholesterol-lowering drug therapy is very important. A complete lipid profile is recommended every 5 years from the age of 20, and persons with a serum cholesterol greater than or equal to 5.2 are at high risk. Diet therapy is the initial. If you have a high cholesterol, typically you start with diet therapy and exercise, and then you recheck at 6 months. If it's still high, that is when you start drugs. So the common drugs here are your statins. They inhibit the synthesis of cholesterol, so you need in the liver. So it inhibits the synthesis of cholesterol in the liver. So it's very, very important that liver enzymes are monitored. Niacin is a water-soluble B vitamin, and it interferes with LDL and triglyceride synthesis. Drugs that increase lipoprotein removal are your bile acid sequestrants, and then drugs that decrease cholesterol absorption are your esotrols. But typically you start with a statin, and then you can add on. Other drugs that are given for individuals with coronary artery disease are aspirin, because they break down the platelets, and plus or minus Plavix, which is also an antiplatelet as well. Things to be cognizant with aspirin and Plavix would be GI upset and bleeding. So let's look at angina. We're going to look at two here. We're going to look at chronic stable angina and prismental angina. So angina is the clinical manifestation of reversible myocardial ischemia. So it's an unpleasant feeling, often described as constrictive squeezing, heavy choking, or a suffocating sensation. It's rarely sharp or stabbing, and it usually does not change with position or breathing. Many people complain of angina as an indigestion or a burning feeling in the epigastric area. So as I've said, it's reversible, so it's temporary myocardial ischemia. So ischemia is not enough oxygenated blood getting to the heart, and it really has to do with the supply of oxygen and demand. So there's an imbalance. So the primary reason for insufficient blood flow is the narrowing of the coronary arteries. Oftentimes, individuals get referred pain to the left shoulder, and it's from transmission of the pain message to the cardiac nerve roots. So it's an intermittent chest pain that occurs over a long period with the same pattern of onset, duration, and intensity of symptoms. So it's the same stimulus that usually turns it on. So although most of the people experience pain seems to be substernally, the sensation may also occur in the neck, and it may radiate to various locations, including the jaw and the shoulders and down the arms. Often people will complain of pain between the shoulder blades and will dismiss it as not being heart related. The pain usually subsides in 3 to 5 minutes. And typically, it subsides when the precipitating factor is relieved, which could be exercise, smoking, stress. The pain at rest is unusual. And when you look at your ECG, it reveals ST segment depression or a T wave inversion. And so we learned about this before when we did our cardiac monitoring. Some people do develop silent ischemia, and silent ischemia it occurs in the absence of any subjective symptoms. It's associated with diabetic neuropathy because their loss of sensation or numbness because of diabetes, and you can confirm it by ECG changes. One thing I do want to point out is that women and men present differently. Typically, women will not present with pain. They'll present with shortness of breath and just an overall feeling of fatigue. Presmental's variant angina is related to a spasm. So it occurs at rest in response to a spasm of a major coronary artery. When the spasm occurs, the patient experiences angina, and you will see the transient ST segment elevation. So it's seen in clients with a history of migraine headaches and Raynaud's syndrome. So Raynaud's is a rare disorder of the blood vessels, usually in the fingers and toes, and it can cause the blood vessels to narrow when you are feeling cold or stressed out. And the spasm may occur in the absence of coronary artery disease. So when the spasm happens, you get chest pain, you get this marked transient ST segment elevation because when the spasm disappears, the ST segment will go back to normal. It may be relieved by moderate exercise. So moderate exercise would increase, and it would increase the oxygenated blood getting to the heart and also break the spasm. Or it may just disappear spontaneously. Calcium channel blockers and or nitrates are used to control the angina. And we'll talk about those medications coming up. So let's talk about drug therapy. The treatment of chronic stable angina is aimed at decreasing the oxygen demand or increasing oxygen supply and reducing coronary artery disease risk factors. And so typically we start off with nitrates. And so nitrates can be short acting or long acting. So your nitrates are your nitroglycerin spray, which is sprayed under the tongue, or a sublingual tablet. And the long acting nitrates are the transdermal controlled release nitrogen patches, nitroglycerin patches, or Izerdil, which is a long form, long acting nitrate, which is given on a daily basis, or BID. And so the action of nitrate is to dilate the peripheral blood vessel, so it's a vasodilator, the coronary artery disease and collateral vessels, and allows that nice oxygenated blood to get to the heart. Okay, other drug supply or drug therapy is beta blockers or beta androgenetic blockers. And so they are the preferred drugs for the management of chronic stable angina. They decrease the myocardial contractility, heart rate, the stroke volume, the afterload, all of which reduce the myocardial oxygen demand. The adverse effects are bradycardia, low blood pressure, and wheezing. You don't give it to individuals who are asthmatics because it can affect the beta receptors in the lungs, depression, and sexual dysfunction. And examples are metoprolol, carvedilol, and bisoprolol. So these are your OLOLs, OLOL. Calcium channel blockers are in addition, or they're usually given instead of beta blockers. And so not in addition, instead of. And so if beta blockers are poorly tolerated or contraindicated, and they don't control the angina, you can give calcium channel blockers. They tend to be the best ones to use in presentals angina for spasms, and they also cause systemic vasodilation. They decrease the myocardial contractility, and they help with coronary vasodilation. And so the examples are diltiazem or cardizem. In addition to your beta blockers and your nitrates, the third drug, which typically is added, are your angiotensin converting enzyme inhibitors. These are your prils, enalapril, ramipril, perindopril, and they are found to work well in individuals or given in addition to individuals who are at a higher risk for cardiac event. So you've got someone who has stable angina, they're a diabetic. So these individuals you would give ACE inhibitors to diabetics. If they have a poor cardiac functioning muscle, you would give it to them, and they benefit from the addition of the ACE inhibitor to the drug regimen already. And so remember, in addition to these drugs, you also make sure that they're on an aspirin and a lipid drug. So it's very common for someone who has angina to be on 4 core drugs, which are your aspirin or your Plavix, so your antiplatelet, one of the two. Your lipid drug, number 3 would be a nitrate, and number 4 would be a beta blocker or a calcium channel blocker. If they're diabetic or they have a poor heart functioning muscle, then you would put them on an ACE inhibitor. So a lot of drugs. So let's talk about diagnostic studies. So typically you would do a chest x-ray to rule out any lung issues, a 12-lead ECG, laboratory test. It's not uncommon to do a stress testing of the heart. And so individuals with stable angina, you want to see what happens when you put a demand on the heart. And the easiest way to do that is put someone on a treadmill, put a 12-lead ECG on them, and watch for any changes in their ECG strips. Coronary angiography is putting a catheter into the coronary arteries and looking to see if there's any blockages. And then there is a variety of other nuclear imaging as well. I want to speak a bit about cardiac catheterization or coronary angiography. It's the same thing. It can be done for 2 reasons. One is just diagnostics, just to look to see, hey, this individual has this stable angina. Is there really something going on that we need to investigate a little bit more? Let's do a catheterization and see if we can identify if there's a culprit plaque somewhere in the coronary care system. The other reason to do it is that you get in there and you notice that there is a plaque that's quite significant. It doesn't mean that maybe there's just one vessel that has a blockage. And so what can be done is a percutaneous coronary intervention, which means in addition to doing the diagnostic look, you can actually open up the coronary artery that's been closed with a balloon, or you can actually put a stent in it. So PCI may not be feasible for all clients. So clients with 3 vessels or significant left coronary artery disease, typically those people would be referred for surgery. But individuals that don't meet that criteria you can have a stent put in or a balloon angioplasty. And because the stents are thrombogenic, which means that plaque can develop on these stents, the client is treated with Plavix or an oral antiplatelet agent such as Plavix, clopidogrel, or aspirin until the lining can grow over the stent and provide a smooth vascular surface. So oftentimes they're on a blood thinner from 6 to 12 months. So I'm going to stop us here and we'll watch a quick video on angioplasty and stent.
The heart relies on the coronary arteries and their branches for its blood supply. Normally, this blood carries oxygen to the myocardial cells throughout the heart. In a patient with coronary artery disease, however, lipids and other substances can build up within the vessel walls. This atherosclerotic plaque can eventually cause the walls to calcify. It also may block blood flow in the vessel. If blood can't pass through the blocked vessel, it can't reach the myocardial cells it normally supplies. Without oxygen, these cells soon die or are damaged. This is how coronary artery disease can lead to myocardial infarction.
Angioplasty is a procedure that restores the flow of blood through the coronary arteries that have been narrowed or blocked by atherosclerotic plaque. To perform an angioplasty, a needle is inserted into the femoral artery. Then a guide wire passes through the needle and is gently advanced through the arteries to the heart. Next, the needle is removed and a small, flexible catheter is slipped over the guide wire and threaded upward. Once the catheter reaches the heart, the catheter tip is positioned inside the affected coronary artery and a contrast dye is injected. Guided by X-ray imaging, the physician identifies any blockages as the arteries fill with dye. Next, a guide wire is advanced and a balloon-tipped catheter is slid over it until the balloon reaches the site of the blockage. Rapid balloon inflation and deflation opens the blocked artery. When blood flow has been reestablished, the deflated balloon and catheter are withdrawn. To maintain artery patency, some patients also receive an expandable steel mesh tube or stent at the blockage site. If needed, a collapsed stent is placed over the deflated balloon before it is inserted into the artery. When the balloon is inflated, the stent expands and locks into position. Then, the balloon and catheter are withdrawn. The stent keeps the artery open permanently.
Okay, so I would suggest that you take a break if you haven't taken a break already. So we've gone from the chronic anginas to acute coronary syndrome. So this is our next topic. So acute coronary syndrome develops when the ischemia is prolonged and is not immediately reversible. And so that's when acute coronary syndrome develops, ACS. So ACS encompasses unstable angina, non-ST segment elevation myocardial infarction, which you now know what it means by ST segment elevation. So these are the heart attacks that don't cause an ST segment elevation rise, or an ST segment elevation MI, which does on the 12 lead cause an ST segment elevation rise. So these are the three types of ACS: unstable angina, a non-STEMI, or a STEMI. So as you could have guessed, it's from deterioration of a once stable plaque. So remember our chronic anginas? Well, now instead of being a stable chronic angina, it's no longer a stable plaque. This unstable lesion may be partially occluded by a thrombus, manifesting as unstable angina, or a non-STEMI, or totally occluded by a thrombus, which manifests itself as a STEMI. So that's the difference. A partial occlusion is typically, we say it's unstable angina or a non-STEMI, and total occlusion of the coronary artery is a STEMI. So let's talk a little bit about unstable angina. So unstable angina is chest pain that is a new onset. It can occur at rest, and it has a worsening pattern. Unstable angina is unpredictable and represents an emergency. So the previous person, so the client that was previously diagnosed with chronic stable angina, will describe a significant change in the pattern of angina. It will occur with increasing frequency and is easily provoked by minimal or no exertion during sleep or even at rest. The client without previously diagnosed angina will describe anginal pain that it has progressively, rapidly changed in the last few hours, days, or weeks, often culminating in pain at rest. Women seek medical attention more often than men when symptoms of unstable angina are present. An MI, so myocardial infarction, occurs as a result of sustained ischemia, causing irreversible myocardial cell death. Between 80 to 90% of all MIs are due to the development of a thrombus that halts perfusion to the myocardium distal to the occlusion. Contractile function of the heart stops in the necrotic area. Cardiac cells can withstand ischemic conditions for about 20 minutes. It takes approximately 5 to 6 hours for the entire thickness of the heart muscle to be necrosed. So this is typically why you need to act very quickly. MIs are described based on the location of damage. So anterior, inferior, lateral, or posterior wall infarction. And location correlates with the involved coronary circulation. So I want to speak a little bit about what I discussed in the previous slide about the occlusion. So this occlusion is happening in the left anterior descending coronary artery, and the thrombus is here. And so there's going to be lack of blood supply distal to the thrombus or the blockage. The left anterior supplies the anterior part of the heart. The right coronary artery supplies the posterior part of the heart as well as the right side of the heart, and the circumflex also goes around and supplies the back of the heart. And so that was the point of the distal part of where the distal part of the thrombus is what is becoming ischemic. So the degree of altered function depends on the area of the heart involved and the size of the infarct. Contractility of the heart is disrupted in areas of myocardial necrosis. Most MIs involve the left ventricle versus the right ventricle. So when individuals have pain, it's typically from total occlusion, and the heart goes into an anaerobic metabolism because there's not enough supply of oxygenated blood. Oxygenated blood provides aerobic metabolism, and you get lactic acid accumulation, and that results in severe immobilizing chest pain not relieved by rest position change or sometimes even nitrate administration. So people would describe it as heaviness, constriction, tightness, burning, pressure, or crushing. Common locations are kind of similar to the anginas, substernal, retrosternal, or epigastric areas. Pain may radiate to the neck, jaw, arms, and back. And for women, atypical symptoms usually are shortness of breath and fatigue. Not everyone has these classic symptoms, and some clients, apart from women, may experience just discomfort or weakness or shortness of breath. Stimulation of the sympathetic nervous system during the MI results in a release of glycogen, so the blood sugar goes up. diaphoresis, vasoconstriction of peripheral blood vessels to try and bring the blood back to the heart. And so your skin will also look dusky or ashen, clammy, and or cool to touch. If we look specifically at the cardiovascular system, initially there's an increased heart rate and blood pressure, and then the BP drops secondary to a decrease in cardiac output. There may be crackles in the lungs. Think back to our left ventricular failure and the backflow of blood into the pulmonary system. Your jugular vein may be distended because the heart is having a hard time contracting and getting blood out, so there may be a backflow of blood into the venous system. And then you may hear abnormal heart sounds, an S3 or an S4. So remember our heart sounds. The third heart sound is caused by a sudden deceleration of blood flow into the left ventricular from the left atrium, so due to contractility issues. And the fourth heart sound is produced by an increase in stiffness of the left ventricle due to scar tissue formation. So that may be something that would happen later on. And then the patient may develop a new murmur as well. And a new murmur may develop because of a mitral valve dysfunction. So something's happened with the mitral valve during the MI, or maybe a septal wall defect. Nausea and vomiting is pretty common. It results from the sympathetic nervous system stimulation of the vomiting center by severe pain. And sometimes people develop a fever, and that's just a systemic manifestation of the inflammatory process caused by the cell death or the necrosis. Within 24 hours, so this is the healing process, so within 24 hours, leukocytes infiltrate the area of cell death. Enzymes are released from the dead cardiac cells, and these are important indicators of MI, and we'll look at these when we look at blood work. And then enzymes of the neutrophils and macrophages remove all the necrotic tissue by the second or third day. We also have development of collateral circulation, which improves the areas of poor perfusion, and that's just an innate thing that our heart does. The necrotic zone is identifiable by ECG changes and by our nuclear scans. Remember that we see an ST segment elevation in a STEMI. We see this pathological Q wave, we call it. So it's a change in the Q wave that will ever be present on the 12-lead ECG. 10 to 14 days after the MI, scar tissue is still weak and vulnerable to stress. And so, you know, these individuals, the heart takes a little bit of time to heal. And so the importance of rest and recovery. These are your ECG changes. And so this is normal. You have a peak T wave that happens. ST segment elevation could be one of these that happens in minutes to hours. There's a loss of an R wave. Remember the QRS? You lose that R wave and you get this larger Q wave development. You may have a T wave inversion, and then the T wave will normalize, but you always have this persistent Q wave. By 6 weeks after an MI, scar tissue has replaced the necrotic tissue and the area is said to be healed, but it's less compliant, so it's lost its contractility. Ventricular remodeling does happen, and the normal myocardium will be hypertrophied. So it's going to be thicker and it's going to dilate in an attempt to compensate for the infarcted muscle. So it's all about, this is the ventricle trying to recover. So what are some of the common myocardial complications? The most common complication after an MI is a dysrhythmias, and they are the common cause of death in patients in the pre-hospitalized period. 80% happen in MI patients, and like I've said here, the most common cause of death in the pre-hospital period. Life-threatening dysrhythmias are seen most often with anterior MIs, heart failure, or shock, and those are the ones that we see are the VFib or a common cause of sudden cardiac death or asystole. Heart failure is another complication, and depending on the severity and extent of the injury, heart failure usually occurs with such signs as shortness of breath, restlessness, a slight tachycardia, Other signs indicating the onset of heart failure include the pulmonary congestion, which you'll see on a chest x-ray, and if you're listening to the patient's lungs, you'll hear crackles on auscultation. So what happens is the pumping power of the heart has diminished. Cardiogenic shock, which we will discuss in our next lecture, occurs when inadequate oxygen and nutrients are supplied to the tissues because of severe left ventricular failure, and it does require aggressive management, and we'll speak to that. Other complications are papillary muscle dysfunction, and it may occur in the infarcted area and includes the papillary muscle that is attached to the mitral valve could become dysfunctional or become ruptured. And it's a rare but very life-threatening complication that causes severe mitral valve regurgitation, and it results in shortness of breath, pulmonary edema, and decreased cardiac output. And so the nurse should suspect a papillary muscle dysfunction if the nurse auscultates a new murmur at the apex of the heart, and an echocardiogram will confirm the diagnosis. Other complications are ventricular aneurysm, and that results when the infarcted myocardial wall becomes thin and bulges during contraction. The client with ventricular aneurysm may experience heart failure, dysrhythmias, and angina. Acute pericarditis occurs within 2 to 3 days after an acute MI and is a common complication of the infarction. It's from inflammation, and it causes chest pain, but chest pain that's different from an MI. It's usually aggravated by inspiration, coughing, and movement of the upper body. And sitting forward often relieves the pain because it's an inflammation of the pericardium. Diagnosis of pericarditis can be made with 12-lead ECGs, but typically the ECG changes are very hard to see because it reflects inflammation of the pericardium. And the treatment is with an anti-inflammatory, often relieved with aspirin or corticosteroids. So how do we diagnose unstable angina and MI? Well, we know our 12-lead ECG will show changes, so it's the primary tool to rule out or confirm unstable angina or an MI. Serum cardiac markers we'll look at on the next slide. Coronary angiography or coronary catheterization plus or minus PCI, which we've shown already with our anginas. So it's a diagnostic tool, but it also can be used to place a stent or a balloon. And also exercise stress testing, and an echocardiogram is an ultrasound of the heart that looks at the ventricular function. So our serum cardiac markers are our blood cardiac markers after an MI. So the tissue will start to release these enzymes, and so we can measure these enzymes to figure out if the individual is the heart muscle recovering. Did they actually have an MI to begin with? Was this chest pain actually related to the heart? And so we look at different ones. The CKMB begins to rise about 6 hours after symptom onset, and it peaks at about 18 hours and returns to baseline within 24 to 36 hours. Our troponin is detectable within hours. It peaks at 10 to 24 hours and can be detected for up to 10 to 14 days. And then myoglobin. We don't tend to use myoglobin very often. We tend to use troponin first and then CKMB. So I've already discussed the importance of coronary angiography and cardiac catheterization. So it's used to locate and assess the blockage and implement treatment if required. Acute coronary syndrome is an emergency management, and the initial interventions are establishing an IV, starting oxygen, administering nitroglycerin, aspirin, or morphine sulfate. And it's important to be monitoring vital signs and pulse oximetry, so ongoing monitoring. The treatment of choice for a confirmed MI is a PCI, and the goal is to open the affected artery within 90 minutes of arrival to a facility with an interventional cardiac catheterization lab. And there can be a balloon angioplasty plus or minus a drug-eluting stent. And I'll talk about what I mean by drug-eluting stent. Well, I think I may have already. Stents are put in place, and oftentimes there are bare metal stents, and bare metal stents what happens until it's covered with a lining of tissue, it can actually be a site where thrombus formation can develop. And so these individuals are on platelet therapy. If someone does not have a bare metal stent, but actually a drug-eluting stent, what happens here is that it does release an antiplatelet for amount of time while the body is getting used to the stent, and it prevents the thrombus formation. Fibrinolytic therapy aims to stop the infarction process by dissolving the thrombus in the coronary artery to reperfuse the myocardium. This used to be the gold standard, but now we can get individuals to hospitals with a catheterization procedure if we can get someone there within 90 minutes, that is the choice, because you can't do both. If for some reason you're in a situation where you cannot get them to a facility, then you would give a fibrinolytic therapy to basically break down the clot immediately. Now, there are some indications and contraindications. So the contraindications are that it can cause bleeding. And so if you are an individual who's at risk for GI bleeds and other forms of bleeding, it can cause bleeding. So the best marker of reperfusion is return of the ST segment to baseline. So if you're giving a fibrinolytic therapy, you're watching for the ST segment to come back down. And then if you give the thrombolysis and it fails, you could ship the person off for a rescue PCI if it's beyond that 90 minutes. And the major complication is bleeding. So as I've said before, your initial management is morphine, oxygen, nitrates, and aspirin, and we call this MONA. So IV nitrogen is used to cause that vasodilation and hopefully reduce the anginal pain. Oxygen to provide that oxygenated rich blood to the heart because it's lacking that. Nitrates for vasodilation. Morphine also is a vasodilator as well, and it's a drug of choice for chest pain that is unrelieved by nitroglycerin. And then your aspirin is your antiplatelet. Other drugs that will be given to someone who's had an MI or unstable angina is anticoagulation through a low molecular weight heparin, which is given subcutaneously, or UH, which is unfractionated heparin, which is an IV heparin drip. They may also be given IV antiplatelets, and then you go into your similar drugs that were given for other anginas, your beta blockers, calcium channel blockers if beta blockers are not useful, your angiotensin converting enzymes. Remember, for those individuals who are diabetics who have poor left ventricular function, you may need to give antidysrhythmic drugs if required, because remember, 80 to 90% of individuals will develop dysrhythmias. And then the importance of cholesterol-lowering drugs and stool softeners, because you want to prevent straining and any vagal stimulation from the Valsalva maneuver. And so you want to make sure that individuals are not constipated. You give stool softeners. You want to prevent any stress on the heart at all. Initially, individuals will be MPO, and then you'll progress to a low salt, fat, and low cholesterol diet. Now, if someone has significant amount of vessels, they may need coronary revascularization or CABG surgery, and it's an intervention to restore blood flow to the affected heart muscle. It's recommended for patients who do not receive a satisfactory improvement with medical management. If they have a left main coronary disease, which supplies a large portion of the anterior heart, or 3-vessel disease. And if you're not a candidate for a PCI, then you need to have a bypass surgery, or maybe you've had a PCI and you have ongoing chest pain. And if you have a history of diabetes mellitus, typically individuals will have a coronary vascular surgery versus a PCI. The research shows that there's just better outcomes. So this surgery does require a sternotomy, so you're opening of the chest wall. It does require that the patient go on a heart pump, heart-lung machine, so you're stopping the heart to work on, and they're on a cardiopulmonary bypass. It's a significant surgery. You can use arteries and veins for the graft. There are individuals that do off-pump coronary artery bypass surgery, and coronary surgery still remains a palliative treatment for coronary artery disease, and it's not a cure. So again, you're putting a bandage on an individual who has coronary artery disease. They still need to fix all those risk factors. So this is just an example. Remember, we looked at this blockage before of the left anterior. And so what happens here is they take an artery or a vein, and this time they took the mammary artery. They attached it to the part of the root or the hump of the aorta, and they bypassed it to the distal part of beyond the blockage. And so now it's going to provide nice, rich, oxygenated blood to the part of the heart that this blockage was not allowing blood to get to. So I'm going to show you a video on coronary artery bypass graft surgery.
Normally, the coronary arteries supply blood and oxygen to the heart muscle. In a patient with coronary artery disease, however, atherosclerotic plaque can build up. If too much plaque accumulates, one or more arteries can become blocked, which can prevent oxygen from reaching the heart. This can cause tissue damage and possibly death. To improve blood flow to the heart, a patient may have a coronary artery bypass graft or CABG of the blocked arteries. In the traditional open heart form of the surgery, a 6 to 8 inch incision is made in the middle of the chest. Then the sternum is cut through and the rib cage is moved to examine the heart. Next, one or more healthy graft vessels are selected for the bypass. Commonly used vessels are the internal thoracic or mammary artery in the chest and the saphenous vein in the leg. Alternatively, an arm or wrist artery may be used. Next, the heart is cooled to keep it still using a heart-lung bypass machine and is connected using plastic tubes. One tube carries blood from the body to the bypass machine, which supplies it with oxygen. The other tube pumps the oxygenated blood back to the body. In essence, the blood bypasses the heart and lungs to get to the rest of the body. Now the grafting can begin. The distal end of the internal thoracic artery is dissected and attached to the left anterior descending artery below the blockage. Then sutures are placed at one end of the saphenous vein to the aorta, and the other end to the right coronary artery below the blockage. When the graft is in place, electrical signals are used to restore the heartbeat. Then the patient is disconnected from the heart-lung bypass machine. Finally, the sternum is wired together and the incision is closed with sutures. Instead of the traditional CABG procedure, a patient may also undergo one of two alternative procedures: off-pump or beating heart CABG and minimally invasive bypass surgery. In off-pump or beating heart CABG, a mechanical device is used to steady the part of the heart where the grafting occurs. In minimally invasive bypass surgery, specially designed instruments are inserted through small incisions in the chest rather than opening the rib cage as in traditional CABG surgery. All types of coronary artery bypass graft surgery allow freshly oxygenated blood to bypass the blockage and reach the distal heart muscle.
Okay, so let's just wrap up with a review of our nursing management for ACS. So acute interventions are going to be your pain relief through nitroglycerin, morphine, and oxygen. You need to be continuously monitoring the patient for ECGs, deciphering whether they're having dysrhythmias. Vital signs and pulse oximetry are done on a frequent basis. And then heart and lung sounds, thinking about what would heart failure look like. So thinking of dyspnea, tachycardia, pulmonary congestion, distended neck veins. Bed rest may be ordered for the first few days after an MI involving a large portion of the ventricle. A client with an uncomplicated MI may rest in a chair within 8 to 12 hours after the event. It is important that the client understands the reasons why activity is limited but is not completely restricted. Gradually increase the client's cardiac workload through more demanding physical tasks, and that's where beginning the cardiac rehabilitation takes place, so that the client can achieve a discharge activity level adequate for home care. And it's important to plan nursing and therapeutic actions to ensure adequate rest periods free from interruption. So the client needs rest as well. Anxiety is common following ACS, and your role is to identify the source of anxiety, assist the patient in reducing it, and provide appropriate patient teaching. Examples of an anxiety could be if the client is afraid of being alone, allow a caregiver to sit quietly by the bedside or to check in with the client frequently. So for you as the nurse to check in with the client frequently. If a source of anxiety is fear of the unknown, the nurse should explore these concerns with the client. The nurse's role can also include talking with the caregivers, informing them of the client's progress, allowing the client and the caregiver to interact as necessary, and supporting the caregiver who will be able to provide the necessary support for the client. The timing of teaching is very important. When clients and caregivers are in crisis, they may not be interested in learning new information. The nurse should answer the client's early questions in simple, brief terms without detailed elaboration. Answers often require repetition and elaboration. As I've said, the importance of exercise that has a direct positive effect on oxygen uptake. It increases the cardiac output, it decreases blood lipids, it decreases the blood pressure, and it increases the blood flow through the coronary arteries. And so it's important. A regular schedule of physical activity is very important to be in place on discharge and for the patient to continue on after discharge. Patients with unstable angina that has resolved or an uncomplicated MI are in the hospital for approximately 3 to 4 days. And by day 2, they can begin to ambulate in the hallway and begin limited stair climbing, so 3 to 4 steps. Because of the short hospital stay, it's critical to give the patient specific guidelines for physical activity so that overexertion will not occur. Patients should listen to what their body is saying. So it's very important to also teach the patient to check their pulse and to know the parameters around their heart rate. The other part that's very important is resumption of physical activity. This is a question that people are very uncomfortable asking, but it's very important that you're able to teach about this. So sexual counseling for cardiac clients and their partners really should be provided. The patient's concern about resumption of sexual activity after hospitalization often produces more stress than the physiological act itself. Before the nurse provides guidelines on resumption of sexual activity, it's important to know the physiological status of the patient. So the physiological effects of sexual activity and the psychological effects of having a heart attack. Sexual activity for middle-aged men and women with their usual partners is no more strenuous than climbing 2 flights of stairs. So the inability to perform sexuality after MI is common, and sexual dysfunction usually disappears after several attempts. Patients should know that drugs used for erectile dysfunction should not be used with nitrates, as it can cause severe hypotension, and even death has been reported. Typically, it's safe to resume sexual activity 7 to 10 days after an uncomplicated MI. As I've talked about, cardiac rehab is really important. Many patients will be referred to an outpatient or home-based cardiac rehabilitation program. Maintaining contact with the patient appears to be the key to success of these programs. One factor that's been linked to poor adherence to a physical activity program after an MI is depression. Both men and women experience mild to moderate depression post-MI that should resolve in 1 to 4 months. So that's important to let the patient know as well. So I'm going to stop here. And please take the time to go back and review these slides. A lot has been discussed in the last hour, and I will see you for part 2 looking at cardiogenic shock.